Well, I think we're
just have the best record.
yeah, the best. And we have 4 more games, but it's getting close. We picked the end in the last.
So we lost. So there's 2 chairs. And we lost our. Yeah, we're going. We got a pretty good offer.
So it's pretty crowded.
Oh, you are? The rare Washington. Yeah. You're just you've been there. You were. Yeah. Of course, we think the reps took the game, you know, how it is for them.
It's 190.
No, it's not that. It's when Pittsburgh beat us in the Super Bowl. They were playing the reps.
I remember one time.
We had a touchdown taken away from the all the time. We got home and run that. So, and then the game was just once you go through yes, I'm pretty sure that was anyhow, flip side, we got the remember we played Free State last year? It was called the simultaneous extension. It looked like we really was intercepted. In fact, we were at the same time we were watching it on TV.
So I ordered this. This is what I ordered.
Now, so if you do it once, you we go, twice a month.
So anyhow,
you can't go through
Pittsburgh started to come back.
regular people in your market.
So they can make it up. So too far out of
It's a long shot. It could happen.
You get a little card.
I did. John's
Like a regular credit card. Basically, interview persons, customs people, and they pre-approve you. And they basically but it lets you skip security at your
yeah, that's my easy one.
Yeah, it's not a great thing.
It's touch and go.
Okay, well, this is very
It's over there. So
It's interesting. It's never, never dull. They're running somebody working up fast.
you have one of the dual things.
I know. I borrowed it. So I didn't want to we were wondering. You know what? It's funny.
Oh, yeah.
Any member of the family.
I vocalize everybody within about 50-mile radius by our I bring people you thought if we can figure out where
I know.
Yeah, where I came from. Tweed Street.
Yeah, you told New York. You could have figured that one out.
You
catch his accent. He's trying to get it for all these years.
Okay, let's go ahead and get started. As you can see, the word of the day for CME credit is velocity. I don't know why. Does it have some meaning to anybody?
Growth.
Okay. Oh, I got it. Growth velocity. Thank you. The sleep this morning. All right. So today's speaker, Dave Skoner from Pittsburgh, very kindly came out here. It's colder here. Tells me that it is back home, which is what he expected. And the other thing that I didn't quite understand about his CV, he lives in Pittsburgh, but he's on the faculty of Temple, which is in North Philadelphia. But the relationship there is that Temple uses Pittsburgh teaching hospitals for his students, so there are a large number of their students training out in Pittsburgh. I'll dispense with the rest of the CV other than say that he's an outstanding member of our allergy community. It's a privilege to have him here. And he's talking about growth velocity and steroids. Dave, thanks.
Well, good morning, everyone. It's bright and early. It's still dark outside. And I know you had a big football game here in the city last night. I have a sense of what it's like when a place lights up over a football game. I know, and again, I'd like to formally thank Len and his group for inviting me here to be with you, but little did I expect that the temperature would be different here than there, and little did I expect that this Seattle would be up on top of the football world and the Steelers would be down on the bottom looking up. I guess that's payback from a few years ago. But at any rate, it's great to be here, and I'm going to walk you through pretty much all you'd probably need and want to know about the effect that corticosteroids have on the growth of young children. And I think this is important for anybody taking care of pediatric patients and even those taking care of adult patients who were once children who used corticosteroids. There are implications for effects on adult height as well. These are my disclosures, and I've had research funding from a number of companies to do work in the growth area, and some of that's ongoing right now, and you'll probably hear about those results in the next 2 years. My objectives are to illustrate sources of systemic bioavailability for inhaled corticosteroids, and as you'll see, I'll speak mostly about inhaled steroids and lung deposition, but there's also the issue of nasal deposition and the effects that they could have on growth as well. I'll talk a little bit about that also. I will also describe the effects of inhaled corticosteroids on growth and on final adult height. So if you have an adult that questions whether steroid use as a child made them short, you might be able to answer this a little bit better. And we'll also review methods to minimize and manage the risk of growth suppression. It's not that we don't use steroids because they may affect growth. It's that we need to manage it properly like we do anything else as physicians. So bottom line is when we inhale, we swallow a certain amount of the drug we inhale, and some of the older drugs have GI bioavailability, like Mometasone and budesonide and triamcinolone. Certain amount that gets into the GI tract gets into the systemic circulation. With the newer drugs, there's almost none getting into the blood from the GI tract. So older drugs had that problem, the newer drugs got rid of it, essentially. However, the drug that you put into the lungs, it really has nowhere to go but into the systemic circulation. And you could say, well, the more you put in the lungs, the more you're going to get in the blood. And in general terms, that is true. So bottom line is, if enough drug from these two sources makes it into the blood, there could be effects on a process like growth of a child the adrenal function of a child, perhaps glaucoma, cataracts, bone density issues, and so on. But we're only going to talk about the growth area here today. I won't really mention much about the adrenal axis. One of the reasons I won't is that most of the low and medium and high doses were defined based on their effects on adrenal. And most of the high doses might have an effect on the adrenal, but the lower ones don't. And you might say, well, they shouldn't have an effect on the growth either. That's really not the case. Most of the time when there's been effects on growth of a lower dose of a corticosteroid, there's absolutely no effect on adrenal axis function. So these two side effects get dissociated from one another. This is a schematic of the growth axis, and in the red are cortisol effects, and you can see they reach their lowest level during the nighttime, and ours are reaching their highest level right now in the early morning. You usually check an 8 a.m. Cortisol level. And you can see the growth axis activity shown by the blue, and pulsatile growth hormone secretion occurring largely at night in the green. And that growth hormone activity stimulates growth. You can see the blue line, but if there would happen to be,
There's a pointer if you want to use that. There you go.
On the mouse? Yeah. So if we would happen to dose a corticosteroid and get a cortisol effect right here, it may blunt this process and reduce the growth axis activity from here down to here, for example. This is what's thought to occur, and one might say, well, if you had once daily dosing option, would you rather give it in the morning or in the evening? And there's been a few studies about that, and bottom line is if you do once daily dosing, probably better off choosing a time when they're agreeable to use it, but morning dosing is probably safer than evening dosing for the reason that you see here. So, the growth effect. Is it real? Is it dose-related? How large is the effect? Do they all have the same effect, all the different corticosteroids? What position has the FDA taken? And as you'll see, they've done a couple of flips with time. And does the effect change our approach to therapy? Should we use non-steroids first? Should we use lower doses rather than higher doses? We'll take a look at some of those questions. Here's a little bit of a timeline, and we had our first expert panel report on asthma in 1991, and that promoted, as you know, heavy inhaled corticosteroid use. And shortly thereafter, there were a number of growth studies conducted, orally inhaled and intranasal steroids. And these were largely phase 4 commitments that drug companies had made to the FDA. When the FDA gave them approval, they said, we'll approve your corticosteroid, but only if you do a growth study, phase 4. Well, most of them delayed the time at which they had to do the growth study. They waited as long as they could until they were forced. And a lot of those studies were done here in the early 90s. And they were not designed, as you could imagine, particularly well. They weren't designed, they had a lot of design flaws, let's say that. Even though they had design flaws, the FDA looked at the results and said, it looks like there's something going on here. Remember the day when we moved from prednisone to inhaled steroids and we said, we kissed the side effects goodbye and we're going to get the benefits of this great class of drugs without the risk of side effects? Well, that wasn't quite the case because the FDA was seeing a signal in these studies, even though they were not designed well. So in 1998, the FDA convened a meeting in Bethesda, Maryland, and I actually attended that meeting. And they pulled in all the raw data from drug companies and did in-house analyses and made a conclusion that there was a class effect, that they all had an effect on growth. So that's our class labeling as it exists today. And they also, in 2001 then, since they had seen all these design flaws, they published a guidance on how this should be done the right way. if you do a study, here's how you do it. So that came out, and then since then, there's been several studies published that used that guidance in designing the study. And as you'll see, it produced some interesting results. And for orally inhaled and then the intranasal, followed the same pathway. So I'll show you some of those results as we move along. As we think about growth, we can think about standing height measured with a stadiometer. This is what's recommended. It's wall mounted. The arm can't move up and down. And, if it could, the old office scale that many of us started our practices with, it wouldn't find the small growth effect that's there. The old office scale would not. Stadiometer can, but you need about 6 months to a year of measurement, standing height, to find an effect. The device on the right is called a nemometer, and it simply measures the length of the lower leg. And that length, changes in that length, can be measured in periods as short as 2 weeks of time. So you can do 2 weeks on a drug, 2 weeks washout, 2 weeks on a placebo, 2 weeks on a different dose or a different drug. And you can do comparative studies in relatively short periods of time with nemometry. The only thing nemometry doesn't do is it doesn't predict long-term effects. It can tell you if there's systemic bioavailability, though, of a corticosteroid. So what did we first learn? This was an early study in the 90s, and this looked at CFC, beclomethasone, and the solid circle is beclomethasone 400 micrograms a day plus salmeterol. The open circle is beclomethasone without salmeterol, the same dose, 400. And then the closed-in squares, the black boxes, are beclomethasone CFC twice the daily dose, 800 micrograms a day. And these are children growing over 1 year of time. And what you see on the vertical is the change in height from baseline expressed as a standard deviation score. So how far away are they from the mean? And if there's no effect over time, this number should be starting at 0 as it does, and if there's no effect over time, it should be tracking right around here. What you can see is that all these lines are heading down, and the two groups that had 400 micrograms a day headed down at this, I'll call it a velocity, since we began with that code word. You can see that, and you can also see that those put on double that dose trended downward at a more rapid rate. And this study is one of the only ones that really looked at the dose-response effect for growth. And you can see that there is an effect of the lower dose, 400, but there's a bigger effect of the 800 micrograms a day. So that's CFC beclomethasone. What about the HFA beclomethasone? Well, this study looked at CFC. The dose was between 200 and 400 micrograms a day. And they also had a group of children treated with the HFA at half that dose, a clinically equivalent dose. And now, instead of height standard deviation scores, we're actually looking at change from baseline in height, in centimeters, over 12 months of time. And you can see that these children here are growing between 4 and 5 centimeters in a year. And you can see the growth rate was published in this. This is a nice publication in Good Journal, Pediatrics. And basically they reported that there's no difference between these. They grew the same on CFC and HFA. And one might interpret that as saying there's no growth effect, but the bottom line is there was no placebo in this study, which is unfortunate because placebo-treated children in almost all these studies grow about 6 centimeters in a year. And you can see the growth here is somewhere between 4 and 5 in a year. But it's kind of interesting if you look at the individual data from that study. On the horizontal axis here is height centile at the start of treatment, and on the vertical is height centile 12 months later. And you can see the line of identity going up, and most of the children fall right along the line. But I do want to point out some outliers. There's a lot of variability here. This child that's circled in red began treatment at about the 65th centile and finished at about the 30th. So it looked like this child had a pretty big effect here of HFA BDP. And if you look at the next one circled, this child began at a low centile and finished at a much higher one. And it may illustrate the fact that sometimes disease can be affecting growth, and if you get control of disease, children can start to grow faster. So this complicates the area as well. And the FDA recognized this at their meeting and said this is one of the complicating factors is disease severity. So moving forward, all you want to enroll in growth studies is patients with mild disease to avoid systemic steroids and to avoid an effect of bad disease on growth. So that's one of the design elements that the FDA recommended moving forward into the future. Yeah.
Did that study have a placebo? Because it looks like it's the same problem as the previous one. You don't know.
Oh, it's the same study. I'm sorry.
Okay.
It is the same study.
All right.
It's just analyzed differently here. Same study. This study did include a placebo, and I don't know if you remember this study, but when we first saw this, we all felt pretty good about what we were doing. Corticosteroids was the main steroid that we were using for children, and this was the first growth study published using it. 100 micrograms or 200 micrograms a day, or placebo. This study did have a placebo. And you can see here the placebo-treated children did grow about 6 centimeters in a year. And you can also see it doesn't look like there's much effect here, right? Looks pretty clean. And that was the conclusion, that there was no significant effect on growth. But I do want you to look at the delivery device chosen for this study. It's the rotodisc. And remember, the more you put in the lungs, the more you get in the blood, the more growth effect you get. The rotodisc didn't deliver particularly well into the lungs. Probably only put about 15% of the dose into the lungs. In contrast, the MDI that we use puts more than that into the lungs, but that MDI that we were all using was not used in this study, unfortunately. But we extrapolated from the rotodisc findings to the broader picture with Corticosteroids, and that was the main steroid we were using. We felt pretty good about what we were doing, not having an effect on the growth of kids with this study. And this was published in 1998.
We had that product in the U.S. I don't remember it. Is this a European study?
No, this was David Allen is an endocrinologist at Madison, Wisconsin. This was done here in the U.S. And there was a rotodisc around for a while here. Yeah. I think it left the market, but it was around for a while. Yeah. But this is what we relied on. And this was a pretty good study. You can see there were 325 kids in this study. So it's a fairly large study at its time. It was a good study, except for the choice of the delivery device.
Did it work for the asthma?
Wasn't done in this study. The rotodisc did work for asthma. It wasn't done in this particular study. What you'll see is there's two kinds of growth studies. One where growth was just monitored in an efficacy study, and another kind of study like this one where growth was the primary outcome and efficacy was probably not even checked. When safety studies are done, safety is the primary outcome, and they're designed for that purpose. This was another study that we published, and this was with nebulized budesonide. This was published in the year 2000, and when AstraZeneca did their pivotal studies with nebulized budesonide, they actually followed them for a while after those pivotal studies were done on drug or on conventional asthma therapy, which would be like the Dacromil or something else. And we ended up with a fairly large amount of data in terms of their growth. with nebulized budesonide. And here we're looking at centimeters per year. Here's the typical 6 to 8 centimeters a year that these children grow. And there's a group here treated with nebulized budesonide, and they're shown by the yellow bars, orange bars. And the red bars are conventional asthma therapy, which would be like theophylline or cromolyn or something else. What you can see here is in the mild group, the mild patients here, there was a significant effect. It was about 0.8 centimeters reduction in growth from a year of nebulized budesonide. But when the two groups with more than mild disease were monitored for their growth, there was no impact of the drug on their growth. So this suggested that maybe the milder patients are more susceptible to this growth effect from a drug. Why would they be? Well, the milder patients, maybe they have less airway inflammation, maybe they have greater airway patency, maybe when they inhale they get more drug into their lungs because they have more patent airways, more drug in the lungs, more drug in the blood, bigger growth effect in the milder patients. That's basically the way this was all put together, and there's really been no further work done with whether or not milder patients are more susceptible, but this study certainly suggested that. We also published a paper on Mometasone. This is, of course, one of the newer corticosteroids, and this study was really not designed the way the FDA said these studies should be designed, but it was a good study nonetheless. And you can see the numbers here, about 40 to 50 per group, per treatment arm, which is the way most of these studies were done at the time. And we had Mometasone, 100 micrograms twice a day, 100 micrograms once a day in the morning, 200 micrograms once a day in the morning, and then a placebo group. Of course, this dose right here, 100 micrograms once a day, is the dose we would typically be giving to children. And here's what that study showed. We're looking here at a mean change in growth velocity compared to placebo in centimeters per year. So the children on the Mometasone here, low dose, which is the dose that we would be normally using, you can see no effect on growth. And you can see that both of the groups that received the higher dose had at least a visual effect, and this group actually had a statistically significant effect. So it's this is an interesting study because you have a no effect dose, and then you double the dose and you get an effect. So in some ways, this adds to the believability of the result of the study. If you prove that you can find and measure a growth effect, at least in one treatment arm, it lends credibility to the study. And that's important for something that I'm going to show you here a little bit later. But this is beginning to suggest that there may be some differences across the various corticosteroids. We can discuss later on, if you'd like, why this could have been the result for Mometasone. Another study that was never published as a full manuscript, but it was presented as an abstract, was with triamcinolone acetonide. Remember the old asthma port with its built-in inhaler or spacing device? Well, there was a big growth study done with it, and this was kind of interesting because the dose could slide up and down. Everything else that I've shown you is really unlike clinical practice because it was a fixed dose for a year, and whatever dose happened to be picked, or delivery device, but everything was fixed for a year. And they enrolled milder patients. This study enrolled more than mild patients and allowed the triamcinolone dose to slide up and down through the year of the study, as you would do in a clinical practice. So it was more like a real-world study than the controlled trials that I showed you earlier, but still, despite that, you can see about a 0.8 centimeter growth effect from triamcinolone over a year compared to normal children This group here is normal, healthy kids on no drugs, no disease. This is a group of asthmatic children being treated with the non-steroids that were available at that time, like cromolyn. And you can see the clear growth effect of triamcinolone. And I think you're beginning to see the size of the effect is generally about 1 centimeter in a year, effect size, which I think you probably knew, and that's probably what you might tell your patients. On a mean level, it's about 1 centimeter in a year. And you can see some patterns here emerging that it's being seen pretty much with every medication that's been tested. And that's what the FDA saw, of course, in 1998. These are raw data from that triamcinolone study, and here's the normal healthy kids, non-steroidal, and the group that received triamcinolone. And this is growth difference that you see up here, from about 3 up to about 8 centimeters in a year. So this would be a normal growth range right here. And I just really want to point out, if you look at the group on triamcinolone, if you look at the bulk of the data points, you can see there's a little bit of a downward shifting. It's not like everybody was down here, growing really abnormally low. It's just a downward shifting in growth velocities to a small extent. But I do want to point out that some of the slowest growers in the study were on triamcinolone, and some of the most rapid growers in the study were on triamcinolone. So having a growth effect from a steroid in a given child is only a risk. Many of them don't have any effect. Some of them actually grow faster on the corticosteroid.
Or were those kids just hitting puberty and that's why they were growing so much?
Most of these studies were designed to avoid puberty. They enrolled kids, like 6 to 8 or 6 to 9 years of age. Avoiding puberty in a primary growth study is critical, as you allude to and would imagine. But most of these studies were designed ahead of time to avoid that problem. They weren't all successful in doing that, and I'll point that out to you here in a moment. But after that FDA meeting in 1998, the FDA class labeled all these drugs, orally inhaled, intranasal, with very specific language that has never been able to go away from any of them. And I also want to point out the classic dose-response effects for corticosteroids inhaled. These are various doses across the horizontal here. And if we look at low doses, which are about right here, you can see there's a dose-response curve that is very steep at relatively low doses for benefit. And as you get up to higher doses, you double, you triple inhaled corticosteroid doses, you don't get much more benefit. So low doses probably give you maximum benefit, minimum risk. What if somebody doesn't do well, a child doesn't do well on low dose? Well, one option you'd have is to step up to medium dose. But when you do that, you don't get a whole lot more benefit, as I mentioned, and all you do is raise the risk of a possible growth effect in a child. So I'm much more in favor of adding on to low doses rather than going up to medium dose in a child that's not responding to low dose. One of the other areas from which we learned about dose responses was using anemometry, the 2 weeks measurement of the lower leg length. And if we look at anemometry and look at percent of maximum suppression at various doses that you see across the horizontal here, it's clear that budesonide, when it was given out of a metered dose inhaler, had dose response effects that could be detected with anemometry. The same was true for beclomethasone dry powder inhaler, fluticasone dry powder inhaler, and budesonide dry powder inhaler. So, using corticosteroids in kids to me is great, but I think I like to focus on using lower than higher doses if at all possible. Now, I did mention that the FDA had their meeting in 1998, came out with class labeling, and they also came up with a template for pharmaceutical companies to follow when they design future growth studies. And one of them was in the population. We mentioned staying away from puberty. So the FDA said, by all means, stay away from puberty. Enroll the mild patients to avoid the effect bad disease has and to avoid prednisone, basically. Prednisone just shuts off growth for a little while. And study design, they had very specific recommendations. They wanted a baseline period before you started drug to capture what the growth was like before you started a steroid. And then they were now assuming that the drug would have an effect on growth for a year. So at the end of the year, they wanted the drug stopped and a follow-up period to see if there was catch-up. So those were all included in recommendations, and they had very specific recommendations about analysis. And essentially what it ended up is instead of 50 per treatment arm, if you did the analysis the way the FDA wanted, you'd end up with several hundred children in a treatment arm. Bigger sample size, you can find smaller and smaller effect sizes. Is essentially what has happened. So, does fluticasone affect childhood growth? It depends on what and when you read. I showed you this study earlier using the rotodisc. And then this study was published by Teresa Gilbert in New England Journal in 2006. And this was actually the study where the fluticasone or Flovent MDI was used in small children. And it was the 44 strength, the most common one we'd use in kids, 2 puffs twice a day with a chamber and a face mask in like 2 and 3-year-old kids. And she looked at the growth velocity, as is on the right, is difference in height change between fluticasone and placebo. And this was a study where, this was the peak study, where there was treatment for 2 years, and then it was stopped, and they were observed. And what you can see is during the 2-year treatment period here, there was a downward effect on growth velocity. And then at the end of 2 years, the treatment was stopped right here. And you can see the evidence here that the children were trying to catch up. After the drug was stopped, there was an attempt to catch up. And this has now been seen in a couple of studies where a follow-up period as an extension of the primary treatment period was included. But the MDI, as you can see, puts about 30% into the lungs, has about 30% bioavailability. And what you can see here is that as we move from left to right on the screen, there's less pharmaceutical influence on design. There's more influence of the FDA, the NIH. The peak study was funded by the NIH. And there's better scientific quality. So as you apply better science to growth studies, you find more and more effects. You can even find smaller and smaller effects that you could say don't mean anything, and we can discuss that a little bit later. So this brings me around to one of the newer studies that was published after the FDA guidance came out. This was actually the Montelukast growth study. So the purpose here was to see if Montelukast affected growth in a year. And they actually included beclomethasone, 400 micrograms a day, as a positive control to see if there was a growth effect, if they could find it. Okay? So this was a primary growth study designed exactly the way the FDA wanted it done. And it included a baseline period, it included a follow-up period. And if we look at length and height for typical healthy boys, and we follow growth over time, in the first several years of life, growth is really heavily dependent on nutrition. The more you feed a baby, the bigger they get, the more they grow. And then for a long time here, you can see growth is really dependent solely on growth hormone. And it's fairly linear. And then during puberty, which we want to avoid, growth is under the influence of 2 strong signals, growth hormone and sex steroids. But the Monty-Lucas growth study, the age group was right here between 6 and 9. So when this study was over, very few, if any, children should have ever gone on to puberty. So this is the way to design a growth study, and the way you should interpret them critically when you do your journal clubs. But 6 to 9 years old is a good age range for a growth study. Well, here's what they found. This is change in height. This is during the baseline period right here. So they're growing at baseline with no drugs involved. And these children had mild asthma, by the way. So they're all growing, the beclomethasone, Monty-Lucas, and placebo. And you can see shortly into therapy here, the beclomethasone group beginning to separate out from the other two. And at the end, Monty-Lucas had no effect on growth, and beclomethasone had the expected 1 centimeter effect on growth. But a good, well-designed study. There's also now a negative study published with flunicillide HFA. It's not on the market right now, right? Nobody here prescribes flunicillide HFA? Okay. Well, at any rate, there's a negative growth study now published with it. And this is another study now that followed the FDA design recommendations almost to a T. And this was published in 2008, and it used Skoner. 40 micrograms a day, 160 micrograms a day, which is a pretty good dose for a child, and then placebo. It had a baseline run-in period, 12-month treatment, and then a follow-up period. And these were children with essentially mild asthma. And the size of the treatment groups, since the FDA design recommendations were followed, look at it. This is probably the largest growth study ever done. Over 200 in each treatment group. And you might say, well, if you do a safety study, you got to make sure they adhere. They use the drug. If they don't use it, you're going to get a negative result, right? So you got to make sure that they use it. And compliance in this study was measured like it was in all the other studies. Canister weights and diaries. And you can see that overall the adherence in this study was very good by those usual criteria. And here's the result. This is the baseline period right here, run-in period. This is the treatment period right here, and then here's the follow-up period. And it's pretty easy to see that all three lines are on top of one another. There was absolutely no matter how you looked at the data, there was no growth effect. So conclusions you can make is this drug had no effect on growth, or the children didn't take the drug, right? Well, you can imagine what the FDA chose to believe. What would you guess? They came out with the guidance in 1998 saying they class effect. So to say that this drug has no effect on growth would deviate from what their earlier recommendations were. So they actually chose to believe that the kids didn't take the drug. So you couldn't believe the result, even though it withstood intense scientific scrutiny at the journal Pediatrics, which is an excellent pediatric journal. It withstood scientific scrutiny there, but the FDA just didn't buy it. They actually wanted the journal to retract the article. This was a fight. The journal editor just couldn't believe. He was talking to me on the phone. In my 30 years of experience as journal editor, I've never seen anything like this go on. But they quieted the FDA down because they let them publish another paper shortly after that about this. But the FDA didn't believe it. What would have enabled them to believe it? Well, if one of the doses, like if there was a 320 microgram dose and it had an effect on growth in the same study, they would have believed that the lower doses didn't have an effect. If the HPA axis, the adrenal axis, had been affected by one of the doses, well, it wasn't. We measured it, and it wasn't affected. If they had webcam proof that the children took the drug every day, that wasn't done, obviously. If you could detect Skoner in the blood, and can you imagine enrolling kids in a growth study and saying we have to get a blood sample? It just couldn't be done. And the other thing that might have made it believable, if you could find an effect on FEV1. but there was no effect seen. But think about it for a moment. The FDA said, well, enroll mild patients. Mild patients have normal FEV1s, right? Baseline. Because there's a placebo group, it's unethical to not give them a drug if they need it, so you have to be able to give them montelukast. So that was given as a drug if they had needed it for asthma. So montelukast can influence FEV1 too. So you can begin to see how complicated it is to do these studies and do them the right way, satisfy the FDA or not.
So as an author on that study, do you believe Ciclesinide is safer and different than other steroids?
I do. Yep.
You think they would have bought it if beclomethasone was in as a positive control? If there was a difference between beclomethasone and Ciclesinide?
I think they would have, yeah. But to do a study like that,
That would have been a real...
you would have to have a double-blind, double-dummy design, right?
Yeah, that says FDA would probably buy it.
That would be tough to get kids to use, I think, a couple of inhalers.
Yeah.
Yep.
If I remember correctly, the original studies with beclomethasone showed that they had a 1 centimeter drop off, but then they stayed there on persistent therapy. And all these studies drop out at the end of a year, and they never look to see what happens after that. Are there any studies that go longer than just
Yeah, I'm
1
going to
year?
show you one here in a moment. I'll show you one in a moment. Yeah, Frank.
Kind of on a similar vein, David, I know a couple studies with budesonide, including the CAMP study, showed this effect on velocity for the first 2 months, in contrast to some of these, and then they seem to actually go back on a fairly normal growth velocity. Do you think that's real, or?
Yeah, I do.
Okay.
I think it happens early.
It sort of makes me wonder about if you pulse patients, are you doing that every time versus actually keeping them on the drug?
The answer is we don't know.
Yeah.
It's a good point, but I think there's a study later on here that I'll show you in a moment that might shed a little bit of light on that, the Trexa study.
And with the question of the deposition of the Ciclesinide in that last study, what's been known when they've done pharmacokinetics in the lungs?
More than 50% in the lungs. It's some tiny particle size. And the deposition study showed more than 50% in the lungs. And these same doses in separate efficacy studies showed efficacy. Irwin Gelfand published studies in pediatrics with efficacy.
Well, since you brought that up, the only 2 steroids that have small particle size and have high deposition, at least according to the manufacturers, are Qvar, beclomethasone, HFA, and Ciclesinide. And I've always worried, because beclomethasone is an early generation steroid, that that's actually a negative feature, at least as far as children and growth, with that product compared to what you just told us about Ciclesinide. Mm-hmm. What's your take on that?
For beclomethasone, I don't think it matters much because it's got high bioavailability in the GI tract. So it doesn't matter if you swallow it or you put it in the lungs. It's getting into the blood. And I think the studies all bear that out. I mean, if you take the old CFC beclomethasone that was putting maybe 20% into the lungs and maybe 80% would go into the GI tract, there was a lot of absorption from the GI tract, smaller from the lungs. Now you take HFA beclomethasone, you put more than 50% into the lungs, it's getting absorbed anyway, and you're still putting 50% in the GI tract, and you have bioavailability there. So for that particular drug, I don't think it matters where you put it, whether it's in the gut or in the lungs, it's getting into the systemic circulation.
But bottom line is you're going to have more concern about growth with beclomethasone than you're going to have with Ciclesinide?
Based on the data and the evidence, yes. More concern. Now, that doesn't mean you can't use it or shouldn't use it. I don't think it really translates into that. It gets more complicated than that. I mean, there's all the other factors out in the real world that matter. Cost of drugs and formulary coverage and all those things. I mean, if we were in a pure world and all we had to worry about was safety of a choice in a child, what we're talking about is relevant and true. But there's other factors that dictate what we do in the real world.
But with Ciclesinide, the metabolism is quite a bit different. Do you think that's played a major role there? Or?
Yeah, I do. I think the degree of protein binding in the plasma has something to do with it. most of the drugs, beclomethasone has about 90% bound to plasma proteins, and it has about a 10% free fraction. So when you put it in the blood, there's a lot free to cause side effects. Ciclesonide and mometasone have about 99% plasma protein binding, a 1% or less free fraction to cause side effects. And I think that's what gives them a different side effect profile. It's consistent with everything that I've seen from adrenal axis studies and from growth studies. But, we don't have a lot of head-to-head studies comparing these drugs in the same studies. Really not. And that's probably what's needed. Well, at any rate, we need longer-term studies. We need to know how to dose, what time to dose, if there's certain populations at risk, genetically or environmentally, and so on. So what do we know about longer-term treatment? Well, the START study followed the group of children for 3 years, and you can see that there was an effect in all 3 years, the biggest in the first year, and then it got less with time, but every one of these differences versus placebo in the START study for beclomethasone treatment was statistically significant. But it does suggest that the effect gets lower with time. This study in the New England Journal of Medicine made us all feel very comfortable. This was a study done in Kolding, Denmark, in a small country hospital, which I happened to visit. And they basically followed children that were treated for a long time with inhaled steroids and measured their adult height on the vertical and calculated what their target would be. And basically, if you look at the line of identity, they concluded there was no long-term effect on adult height. This made us feel pretty good. But it's not a well-designed study. The CAMP study that someone alluded to here a moment ago was a pretty good study. And it wasn't a great study for growth. It was good for its primary outcome in the lungs, but they monitored growth as a side issue. And the age at entry in CAMP was 5 to 12. And as you could imagine, if you put a 12-year-old in CAMP and followed them for 5 years, which CAMP did, most of them would go into puberty. But if you enrolled a 5-year-old at the end of CAMP, they were 10, they probably wouldn't have gone into puberty. So this study was really complicated by puberty, which makes it amazing that they would actually find anything. But they did. As Frank alluded to, they found an early growth effect here from budesonide, and then it seemed to go away with continued treatment. The velocities of budesonide were very similar to nadocrimil and placebo for the latter part of the CAMP study. And this resulted in a prediction that these kids would reach their final predicted adult height. So we felt pretty good at that time as well, until the children that were in the CAMP study were followed up when they were adults, which is out here. They were about 25 years of age. And here's the growth effect that was seen during the CAMP study from budesonide at the end of CAMP. And these children stopped CAMP therapy right here, and then they followed them up when they were adults, and they were still short. Kids that were treated for 5 years in CAMP with budesonide were still short as adults.
1 centimeter.
Yeah. Yep. And this is a low dose, by the way. So, does the use of inhaled steroid budesonide in childhood affect final adult height? It depends on what you read, the New England Journal of Medicine. You read it in 2000, as Regis McFadden called this, it's the New England Journal of Fashion, called it. New England Journal of Fashion. But in 2000, there was no growth effect. In 2012, there is an effect on adult height. And what's happened here is better science, essentially. Free from pharmaceutical biases, better design, NIH guidance, and so on. But I still don't think CAMP's the best study for this purpose yet. So Frank asked a question earlier about what if you use these intermittently? Do you get a new growth effect every time you start them up? And would you end up being worse in the end? Well, the Trexas study would argue against that. They had, this is growth that you see here, mean growth in centimeters over a year of time. And there are 2 regular BDP treatment arms in this study, shown in the red, and 2 intermittent BDP use groups. So instead of being on BDP every day, they used it when they needed it. And you can see as well as I can that both intermittent treatment groups lost the growth effect that the regular treatment had provided. So this would suggest, and by the way though, it seems to take about a month or 2 to get the growth effect. These kids might have used intermittently for 2 or 3 weeks at a time. So maybe they're under the window of when you might get into that kind of problem. But this suggests that intermittent therapy might make this problem go away. So what about beclomethasone HFA, which was what was used in the Trexas study? Well, does it affect growth? In the earlier pediatrics paper that I showed you, they said it didn't. And in the Trexas study, it certainly does. And this was a low dose, by the way, in the Trexas study. And I'll show you that here in a moment. Again, this is better science on the right. So I tried to put into perspective here all the studies on one slide that I showed you. This is the reduction in growth in centimeters per year. And if you scan this, you can see that most of the studies that had an effect, as we mentioned earlier, was about 1 centimeter in size. And I do want to point out that there are some no-effect drugs and doses. I alluded to 2 of them, Skoner and Mometasone, and Flunisolide HFA. And the ones circled in the green are low doses of that particular steroid. The Trexas study that I just showed you was only 40 micrograms twice a day. 1 puff twice a day produced a 1 centimeter reduction in growth velocity. What about nasal steroids? The first intranasal steroid growth study published showed that beclomethasone certainly had an effect. Spray beclomethasone in the nose, you swallow a bunch of it, you might get some absorption across the nose. It produced an expected growth effect, although it wasn't expected in the year 2000. It would be completely expected today, but at the time we did this study, it was completely unexpected. This was a completely surprising result, totally. And then the follow-up study with Mometasone showed no growth effect. And in fact, follow-up studies with a number of other drugs showed no growth effect. Budesonide, Corticosteroids. These are sprayed in the nose now. These are intranasal studies. And this first one was anchored in 2000. And what I did here, this is a slide I presented at the FDA public hearing in July. And I put the studies up here that were before the FDA guidance and the 2 that were designed after the FDA guidance came out, and these are both unpublished. And you can see take a look at the sample sizes here in these earlier studies, about 40 to 50 per treatment arm. These are the 2 studies designed according to the FDA guidance. They have more than 100 in each treatment arm. And again, by the way, both of these are unpublished. This is triamcinolone. This is the one that's going over the counter, down to 2-year-olds. It's going to be sold to 2-year-olds over the counter. Only country in the world where it's down to 2. And this is fluticasone furoate right here. And you can see the growth effect was 0.45 centimeters per year. So remember, with orally inhaled, it was typically 1. Now, with these larger sample sizes and more attention to detail, we're actually able to detect effect sizes of less than a half centimeter in a year that are statistically significant. The fluticasone furoate study, also unpublished, minus 0.27, a quarter of a centimeter per year, statistically significant. So better design, focus in on what you're looking for, and you find it.
So what was the discussion when you presented that data on the half a centimeter with the triamcinolone?
I think that the decision had already been reached, that it needed to go over the counter because patients wanted access, patient groups, advocacy groups wanted patients to have access, and I think that someone wanted to save money, insurance-wise.
But was there comments made when you presented that?
Oh yeah, I presented much worse than this. I presented a case of unmonitored therapy gone bad, where a child almost died of adrenal suppression. But I think it swayed some of the votes, but the FDA, their main point of discussion was, going over the counter, was, are we going to affect the growth of children? Because they saw the study. And they felt that they could control or mitigate the risk with labeling. Labeling saying that if your child takes this drug, contact your doctor. Or use it for a short period of time. If you need it for longer periods of time, contact your doctor. Or this product may affect the growth of your child. This is not directed to us now. This is directed to a parent going and buying this over the counter for their 2-year-old. So they felt that the risk was there, and some felt it couldn't be mitigated with labeling, and 10 people, 6 felt it could not be, and they voted against the switch. 10 felt that it could be controlled, and they voted for the switch, and 2 abstained. And it's kind of interesting, the allergists that were on the FDA Advisory Committee all voted in favor of the switch, pretty much. It's kind of interesting. Yeah.
When I see the FDA approving that half centimeter or passing on that, I wonder to myself, medically, legally, do I worry about 1 centimeter in my practice? You know, the FDA is now basically saying that we can dismiss a half centimeter. What's 1 centimeter? Do we bring this up with patients? I mean, I will anyway, but legally.
They're sending clear mixed messages, aren't they? They came out in 1998 and said these all have a class effect. You got to worry about this. Use non-steroid alternatives. And now they made an about face and said it's okay to use this one that we know affects growth down to 2-year-olds. I don't know. I don't know exactly what all the medical legal implications of that are, or how that should modify, if at all, our discussions with patients. That's an interesting.
Has there been tort, where a physician is sued for loss in growth or terminal?
In a child that wanted to play for your basketball team here in Seattle, might make a difference. To my knowledge, no. But you can realize easily that there's probably no risk for the FDA here, because how are people using these in real world? They're not using them right. They'll use them for a week or 2 and there's no benefit and they'll stop. So they're probably not using them well enough to get the problem. So I don't think there's really any risk at all, because people are going to buy it, waste their money, not use them right, not get the benefit, and not get the problem.
Well, isn't that true in real life with the use of inhaled steroids?
Absolutely.
This is all moot because in the real world.
Absolutely. And I have a cool slide in here. The adherence you're talking about goes down with time. And I think adherence hurts us because the outcomes of asthma haven't changed in 10 years with guidelines and drugs and everything else. But we don't see growth suppression or adrenal suppression either. So the low adherence hurts us. For efficacy, it helps us from a side effect standpoint.
I've got a question here from one of our virtual audience.
Yep.
What's the real effect of low-dose inhaled steroids with 1 to 4 exacerbations a year requiring oral steroids versus medium to high-dose ICS? Basically asking, is it worse to give people repeated bursts of oral prednisone versus inhaled on growth?
Yeah, that is a great question, to which no one really knows the answer. I would guess, it's not been well studied, but I would guess that 4 bursts of prednisone a year on top of low dose would probably be worse than steady medium dose with no prednisone over the year. And the reason I say that is in all the studies, the immunometry studies where prednisone was given, it just shuts off growth completely for a while. But it's not been studied. No one has an interest in learning the impact of prednisone on growth. There's no pharmaceutical company that has an interest in it. Yes?
In the old studies, there was some suggestion that it delayed growth and it was caught up at the end, and these kids on steroids grew longer than the kids off steroids. Has that data been pursued, or is that just not the case? anymore.
I don't think it's the case anymore. I mean, the CAMP study followed kids until they were about 25 years old, and they were all done, obviously growing by that time. And they still had the growth effect. Most of this studies I think that you're alluding to talked about delays in onset of puberty in kids with asthma, and they would be delayed, but they would ultimately catch up. But I think the CAMP study would speak against that, where they were followed to
So do any of these studies support more than a 1 centimeter total growth suppression over time?
But, I mean, these are mean values that I've shown you. There are children in these studies that are growing 1 and 2 centimeters per year. So I think that highlights the FDA's recommendation to monitor growth. Now, what if you put a child on low-dose inhaled steroid and you follow them for a year, and at the end of that year, they've only grown 2 centimeters? What in the world do you do with that information? Is it the drug that did it? Is it normal variation in growth, which happens? You can grow slowly for two years at a time, and then all of a sudden you pick up spontaneously. Is it bad disease affecting growth? How do you make those decisions? It's hard. You can't really, I mean, somebody mentioned about legal implications. You can't really say that the drug did it because there's so many other variables in the equation. Yes?
You showed much earlier that there was a direct effect on growth by severity of asthma if you compared the mild versus the moderate severe. Can you speculate at what point, based on severity of asthma, is it better to give the inhaled steroid than not?
No, not on any kind of numerical scale or basis like FEV1s or something like that. There were studies, I'll just mention this to you. Everything I showed you here is pretty much growth, but there are studies looking at plasma cortisol levels and the effect that inhaled steroids have on those levels. And what they found was they found a relationship with the FEV1 of the patient. The higher the FEV1 was, the bigger the effect on plasma cortisol was of delivering a given dose into the lungs. The lower the FEV1 was, the more obstructed the airways were, the smaller the effect the drug had on adrenal axis function. That was another study that suggested the same thing, that patients with lower FEV1s that had more airway obstruction are probably not getting drug delivered into their lungs as well, probably not as big an effect on cortisol levels, and maybe not as big an effect on growth, but there's no way to do that. I think following the guideline is reasonable. Where you have a patient with mild disease, you can choose between a steroid and a non-steroid, and the steroid would be a low dose. If you have a patient with more than mild disease, you probably need to go with an inhaled steroid right off the bat. And I always like to start it low and work high. I know some of our colleagues like to start high and work low. And that's a nice process to follow as long as step down is done, if it's warranted. But I have a study later in this thing, probably 2 slides away, but there's a study at the Mayo Clinic showing that children that were eligible for step down were only really stepped down about 20% of the time. 80% of the time they were left at the dose that made them well, and they weren't getting stepped down, which is unfortunate. Len?
Since we all believe our own patients are fully adherent to somebody else's patients who aren't, one of the take-home messages I'm getting in the real world, I'm an internist anyway, it doesn't really affect me very much, but if I was treating young kids, that Mometasone and Ciclesinide are truly better. This is not totally a class effect, and if I could choose, and insurance would pay for it, those 2 drugs are better than the others, and I should stick to them. Would you agree with that?
In principle, yes, I would agree with it. In the real world, it's harder to follow that. Mometasone is an easy one. It's approved down to 4, so it makes sense, and the data are the data. Now, you could say, well, maybe there's flaws in that study, that there is a real growth effect and you just didn't find it. You could say that. The FDA didn't say that. But the Ciclesinide, the FDA said to you, you shouldn't believe that result. And they only approved it down to 12. So even if you wanted to give it to a 4-year-old, you could do it, but it's not approved, so it might not get coverage for that patient. So that's where it got hammered. It didn't get approved under 12, even though it probably should have, would have. Just didn't happen.
I sort of was under the same impression as Lynn, that initially it seemed like you were going towards Ciclesinide and Mometasone were better steroids, but then at the end it seems like it doesn't really matter which steroid you use. Is that the overall message here?
If you buy what the FDA says, yeah, it doesn't matter which one you use, and it doesn't matter if you get it over the counter or you get it by prescription. I mean, they all have the same possibility of an effect. Now, even in these studies where there's no effect on mean levels, you could still find children, outliers that have their growth affected. That's the reality of it. No matter which steroid you choose, you're probably going to find some children that have their growth affected, others not. With a given drug like beclomethasone, the frequency of finding those low growers is probably higher. You're going to find more of them. That's the bottom line. But still, even on beclomethasone, a lot are going to grow quite well. So it really comes down to us in our clinical practices monitoring growth and using the lowest effective dose. So can't go wrong if you monitor growth and use the lowest effective dose. What do you do with the growth findings when you get them? That's another critical question that I mentioned in passing a moment ago, but how do you interpret declines in growth velocities? Is it disease? Is it drug? Is it natural variation? Is it something else that I should be worried about? All of the above? I mean, I guess that's where the skill of us in pediatrics comes into play, is trying to identify that. But, the adherence rates are so low. I mean, I asked this question at the bottom. At the Pneumococcal Asthma Conference, have you ever seen growth or adrenal suppression from an inhaled steroid in a child with asthma? And these are pulmonologists and allergists from all over the country. And 58% of them said, no, never seen this before. So it's not being seen much in clinical practice now. You might say, well, maybe it is there, and we're just not detecting it or seeing it. And that's probably more the case. Growth can go wrong for a lot of reasons other than inhaled steroids.
Any comments, just changing the subject slightly, any comments about inhaled steroids and nasal steroids and glaucoma and cataracts?
Yeah, none of the big studies that looked at these issues, there was some publication in the New England Journal of Medicine a few years back, and JAMA and some others, but they were case control studies, largely epidemiologic studies, and most of them found no evidence that the nasal steroids had any effect on the eyes. And most of the studies found no effect of lower doses of inhaled steroids, orally inhaled, on the eyes. But as you increase the dose of the orally inhaled, more into the lungs, more into the blood, the risk of cataracts and glaucoma went up, without doubt, in the higher doses. So there it's a dose issue. It's also a dose issue for the adrenal gland. There's clear dose-response effects on adrenal axis function. But usually at the lower and the middle, medium doses, there's no effect on the adrenal at all. It's only when you get up to the higher doses do you get the risk. And even then, it's just a risk. The problem is if you exceed recommended doses. The recommended doses have been studied and tested. If you exceed those, you're in a strange, undefined territory where there's probably much greater risk. Do you remember when fluticasone was approved? It was first approved in Europe. And at the time, before it was approved, there was a lot of beclomethasone use, and they were seeing steroid side effects, and there was a lot of prednisone use, and it had all these bad effects. And then when fluticasone got approved, they said, wow, this is like, as you saw from the growth study, it's like a miracle drug. You get the benefit, walk away from the risk. So the approach that they took was to use it like candy. And what they did is, if you didn't respond to this dose, you moved up to this one. If you didn't respond to that, you kept. And the rationale was it was always safer to do that than put the patient on prednisone. You'd probably agree with that. But what they did is they kept pushing these doses up way beyond the doses that were studied. for safety. And they got into trouble. A guy named Todd published a whole case series of kids in the UK that had adrenal crisis. And some of them might have died, but they had bad outcomes. And it was mainly related to very, very high dose of fluticasone. So if you stay within recommended doses, and by the way, you know that there's 3 strengths of fluticasone, right? 44, 110, and 220. Are all those 3 doses approved for children? Does anyone know which of those doses are approved for children?
It's just 44. Certainly 44. I'm not a pediatrician. I don't know.
It's not fair then. Does anybody think the 110's approved for kids? Surely someone does. Because at the Pneumococcal and Asthma conference, the pulmonologist and the allergist didn't get it right there. The only dose that's approved is the 44 strength for kids. And that's because it was studied for safety and efficacy, both. The higher doses in kids are probably not real safe. That's the bottom line. The other strengths are, of course, approved for adults.
Has anybody ventured into the quagmire of pregnant women and inhaled steroids, or is that still, you're on your own if you use inhaled steroids in pregnant women?
I think you're on your own. There were some studies published showing that inhaled steroid use during pregnancy didn't affect the growth parameters or the height or length of weight or length of the child that was born from that pregnancy. But they're small studies, they're not big, they're not prospective, they're not well designed. They're just monitoring outcomes of pregnancies where inhaled steroids were used. But overall, they look safe.
I just wonder if they're going to let triamcinolone go over the counter. You'd think they would have looked at the pregnancy issues with that because they'll no longer have any control.
Yeah, that's a good point. And I don't even know that obviously wasn't the object of their attention at the meeting. It was all on the growth area and this. But that would be another interesting area. And I don't even know if they've made recommendations about labeling for pregnant women. I'm sure they will. It may be similar to what's in the prescription product right now, which is kind of, use it on your own, something you don't know if something's going to happen or not. If you don't need it, don't use it kind of thing. I don't know if they'll recommend that pregnant women see doctors before they use it or not, but there's no control over that. There's going to be plenty of 2-year-olds that will get triamcinolone. And they'll never call you or their doctors. These are patients that don't want to see a doctor in the first place. And there's a lot of them, and more of the time, they just don't want to see doctors. And that's why the patient advocacy groups were so vocal at this meeting. 2 of them stood up and just said, this is the best thing since, chicken soup for a cold, pumpkin pie. Drug going over the counter is the best thing America's ever seen. They stood up and said that in front of the FDA, and then the rest of us stood up and said it's the worst thing you could do. So the vote was 10 to 6 to 2 to put it over the counter.
What do you do in the real world as a pediatric allergist if a mother has steroid phobia and you have to make a choice with a child, prepubertal child, as far as asthma?
Mm-hmm. Give them a trial of Montelukast. And then if they don't...
Let's say like an 80%, that's not good enough.
Then add a low-dose inhaled steroid.
Do you matter which one? You care with all this data which one you choose?
Well, I have to be honest. Usually I'm not given that choice. Usually some insurance company will... They second-guess just about everything I do. And it's, if I decide to put them on Mometasone, they come back and say, no, you have to pick either Cuvar or Flovent kind of thing. But... My go-to drug in a child is Mometasone. I like it. It's once a day. It's easy to use. Approved down to 4, and the dose that's approved had no growth effect. You can't really go wrong with that choice, in my opinion. Ciclesinide, I think, is a good choice, but it's not approved under 12. And everything else had an effect on growth, but some of them are cheaper than others. Probably for that very reason.
Well, that's what I'll remember. At my age, you can't remember much. So if I get 1 point, I'm happy.
Well, thank you very much. Thank you for your attention. Go Seahawks.
You're all going to need it as well. It's going to be a short one. I've got one for you guys.